Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, we are sitting down with a very, very special guest. We've kind of been on a surgeon kick lately, Brett. And so we just had Dr. Anthony Romeo from Chicago on our podcast. And now we're going to switch gears a little bit with surgeons. And of course, if you're watching on YouTube, you see our parasitic infection on the screen too, which is the Dr. Lindsay Mumma. And so we can't get rid of her. She just keeps coming back. But no,
she's like a turd that just won't flinch. I mean, we keep trying. And
no, we are very excited. So when we were in Raleigh, Lindsay started talking about this surgeon that she has been referring to back and forth. And then also she had the chance to sit in on some surgeries. And this surgeon is not like a normal surgeon. This is a plastic surgeon, which is Dr. Jeremy Pyle. And so Jeremy was basically kind of blew your mind when it comes to abdominal wall surgery, especially when we are working with your population, which would be postpartum females. And so, Lindsay, I don't want to do it a disservice by kind of introducing Dr. Pyle, but I would love it if you would kind of kick things off and like, where did you find him? And, tell us about your experience with him.
So thank you for stating that postpartum women are my population. Like I own this population or something. These are my people though. And I will tell you, I have been so surprised by the number of women who have had tummy tucks. And it became kind of like a fun thing that we did at the pool. I would point them out to my husband. So my husband has been a swim coach since he was 17 years old and works at a pool in the summer when he's not teaching high schoolers. And we would start to pick out the tummy tucks. And it was actually pretty obvious because one of the things that's missing from an abdomen that has been surgically altered is any sort of undulation that happens with normal, just fat accumulation, muscles, fascia that's moving. And it looks very unnatural, even to a very untrained eye. So, my husband has had the benefit of being married to me for 13 years, but he hasn't really trained his eye musculoskeletally like I have. And he would point people out to me at the pool and be like, that's a tummy tuck, isn't it? Yes, that's a tummy tuck. And you can see it from here. And so I had a couple of patients who came in and I was like, oh, this is actually like a good tummy tuck. I don't think my husband could pick this out off the side of a pool. This does not look like a surgically altered abdomen. This looks like an abdomen, and it happens to have a scar on it. Now, because I'm sort of obsessed with taking care of scars, I ended up seeing these tummy tucks more intimately than most people would. And what I was noticing was how much healthier the actual scar itself was. And so I had been looking at abdominal scars because of cesarean surgeries. And when I came across my first tummy tuck was actually when I was interning at Mark King's office. A woman crawled into the office on hands and knees, and she just had this horrible low back pain. She couldn't stand up straight. And she said, I had a tummy tuck. It was like 4 or 6 weeks before that. And then all of a sudden she woke up, she got out of bed and she hit the floor and she could not get up and crawled to her car. Her husband drove her to the appointment. She crawled into the office and literally could not ambulate upright because she didn't have enough core stabilization. And so that kind of stuck in my head, but I didn't really think anything about that until I started seeing patients post abdominoplasty on my table. And it's basically like a C-section on crack. So even though we're not cutting into the uterus the way that we do in a cesarean section, the layers of cuts that happen and then the reattachment of tissue from further up the abdominal wall to the lower abdominal wall and the stitching that's happening underneath really kind of creates a ton of scar tissue, which then limits the ability of the abdominal wall to move and obviously will create inhibition of respiration and abdominal wall function and posture and stability. So I've done a lot of rehabilitation with these patients, and it was truly amazing to me that I could tell this surgery was done differently than this surgery. Like if you show me a meniscus surgery, I'm like, that one kind of looks like that one kind of looks like that one. a couple of differences in some ACL surgeries here and there, but like in general, an ACL surgery looks like an ACL surgery. I could tell that some of these surgeries actually looked different than others, and I couldn't quite put my finger on what it was. And then one of my patients said, I'm gonna tangent here for a second, because I will tell you I had a strong bias against abdominoplasties, right? I want to improve abdominal wall function. I want to help women feel comfortable in their body. I want them to understand how important it is that their core and pelvic floor are working together. And so surgery is like not that in my mind. And it was all just for aesthetic purposes. And I was very judgmental about it, 100% clear. And then one of my patients who had postpartum depression and had 3 C-sections that she didn't want to have. So the first one she didn't want to have, and then ended up trying for a VBAC, didn't have that. She ended up having a second cesarean. So then automatically had a third cesarean, and she had postpartum depression, ended up gaining a bunch of weight, wasn't really taking care of herself, got herself to a healthy mental space, and started working out, taking care of herself, was doing really, really great in rehab. And one of the things that happened was the skin that had been stretched was now hanging over her cesarean scar. And so she could not keep that area dry, and she was getting yeast underneath of her skin. So she had lost 80 pounds, was feeling great, but then also wasn't feeling great because she couldn't feel healthy in her own skin. And so she wanted to just get that extra skin removed, and had consulted with Dr. Pyle's office and found out that actually the really only fix that we could do for this would be an abdominoplasty. And she came to my office and she was like, I just never thought that I would be a person who got a tummy tuck. I kind of had a perception of what that person was, and it wasn't me. And that sort of opened my eyes to, I've been hugely a judgmental bitch about this, because there are people who just want to feel better in their skin. And if surgery is the way that they do that, and we can do it from an intentional standpoint, then I think there's probably a space for this that I could open my mind up to. So when she said where she was consulting, I was like, you know what? That's the place that these other patients who have had tummy tucks that I could not bounce a quarter off of. Because that's one of the things, when these women have had tummy tucks that are not done in the way that Jeremy does them, their abdomen is so tight. There's no undulation. It is just an actual drum, which sounds like maybe what women are looking for when they get a tummy tuck, but it's not. They're so dysfunctional because there's so much tension without there actually being like shared load transfer throughout the abdomen. So it kind of stuck out in the back of my mind, like, oh, this is actually probably a good practice. She asked if I wanted to shadow her surgery. Unfortunately, I was already teaching that day, so I couldn't go to her surgery. So I reached out to Jeremy's office, and crickets. They kind of ghosted me a little bit because he's got good gatekeepers. And so
I wondered if that was going to
my
come up.
husband, who can pick a tummy tuck out of a lineup, right? He was like, hey, haven't you been trying to get in touch with Amelia Aesthetics? And I was like, yeah. He goes, that's Dr. Pyle right over there. My husband is coaching his kids on the summer swim team. So
Wonderful.
Full circle to my husband here. He pointed Jeremy out at a swim meet. So I went over, I was like, hey, I'd love to meet you. You do great tummy tucks, and I take care of them afterward. And so that is kind of how I got to know him. And then I had the opportunity to actually witness 2 of the surgeries that he did. And he described to me in detail, how much palpation that plastic surgeons actually use. And I saw him do it. And that just excited me, because palpation is the bread and butter of a chiropractor. Like, this is how we actually function well. And so it was exciting to see someone kind of what I would think of as maybe the other side of the aisle using our like really important technique here. And he also demonstrated how he was creating a surgery that was giving us the outcome that I could see on my table was already more functional by the time they got to me. So with that very long introduction, that is how we got here. And it's been
Dr. Pyle,
really
you still
cool.
there?
Yeah.
Yeah, here's the thing. If you ever say kind things about a plastic surgeon, we're not going anywhere. We will listen forever.
Right.
Is there anything else, Lindsay? Carry on.
I mean, I could obviously go on for hours at a time here, but it was completely different. And now when people come into me, I can recognize an Amelia surgery versus another surgery right off the bat. So it's really impressive.
Well, I think it brings up a good point, because whenever we're even in the treatment room outside of surgery, we're always looking at tension being an issue. And obviously, Lindsay, you've talked about that extensively when it comes to the pelvic floor, but then how the pelvic floor resonates with the abdominal wall. And so, Dr. Pyle, can you maybe talk through, like, is that something that you've picked up along the way? Is that always been in the back of your mind to not create the tension, or is that just kind of, oh, it's just how I do it? Like, where did this kind of this technique or your ability to kind of create these miracles, as Lindsay's calling them, come about?
Or was it more of a cosmetic versus a functional thing too, maybe?
Well, so yeah, both all of that is true. And for what it's worth, Lindsay's perspective that she expressed early on about not wanting to believe in the value of cosmetic surgery, I also was in that camp. For the first couple of years of my practice, I didn't do hardly any of this. And then my mom had a surgery and she was like, I finally feel how, rather, I finally look how I feel. There's no more dissonance between feeling one age and looking a different age. And she's like, I don't do this for anybody else, man. I just feel better when I look in the mirror.
Mm-hmm.
And I was like, oh, mom, that changes things because, you know, I love her dearly and she's amazing. And so seeing my own experience of that, I was like, well, maybe there's something to this. And now 13-ish years of doing it, this surgery, mostly cosmetic surgery, there really is like something to it. We don't treat Kardashians, we don't treat celebrities. Like for the most part, it's just normal people who want to feel good when they go to their closet in July and pick out a t-shirt to go to their kids' event. You know, it's not like it's not some ridiculous ideal. So that was how I also got drawn to plastic surgery, cosmetic surgery specifically. How Lindsay described our meeting was exactly correct. I was like, how'd you find me? No, no, it was easy once we met to get past that. But there are people. I mean, our office gets a million calls a day from somebody selling something, and some of them are wonderful, but many of them are a bit deceptive, and it's hard to know. I'm thankful that Lindsay did not give up. Thank you for reaching out, Lindsay. To answer the question about what is done differently, it's intentional in that I only do 6 operations. So most plastic surgeons, and our practice is kind of like this. Most plastic surgeons will do 30, 40, 50, 60, 70 different types of operations. And I really only do 6. And so like, it's just a little bit easier to be more thoughtful with 6 things instead of 70 things. There are some surgeons who can be thoughtful on all 70. I'm just not capable of it. And then like, I've learned that you don't get to pick what you're going to do as a plastic surgeon. People will pick it for you. And so I didn't like select to do mostly tummy tucks. It just happened that way. And it wasn't because I was like, I have a new way. Every year I try and pick 1 or 2 things inside the surgery to specifically work on. Like 1 year was the muscle repair. 1 year was the belly button, so it doesn't look weird. 1 year was scar position. So like some of it is just sort of built on itself over the years. And then it's just like, I've been doing it for long enough and I do the same thing and I do it over and over and over again. The team in the operating room holds me accountable to stuff. If they think something isn't quite right, they'll tell me. And so there's just been all these external forces that I think have made the operation a little bit better in the last 10 years or so.
Lindsay, are these patients people who have loose connective tissue, or what predisposes them to the issue, do you think?
Well, so actually, Jeremy and I talked about this. I was talking to him about a patient of mine who had had a hernia repair, but she has EDS. And so after she had the hernia repair with mesh, she then was pregnant with twins, and the amount of fascial damage that she had because she had mesh in her abdominal wall and also had a connective tissue disorder, she had a massive diastasis, functionally speaking, which I'm going to put a pin in that because I definitely want Jeremy to talk about this. And he said, and I said that we were able to actually get her to a place where she's not in pain walking around day to day, which she was like for the first several months after giving birth to her twins. She came to my office. We started doing a bunch of DNS rehab, and she's now in a great place. And he said that's great because those patients with connective tissue disorders actually they don't respond as well to surgery. Mm-hmm. And that to me is really encouraging for the type of rehab that we're doing, because in my mind, if they're so far gone that they would need surgery in order to be functional, like that's the type of patient that would be, right? Somebody who has connective tissue disorder and they're really unstable. We actually are their only hope as chiropractors who are doing DNS, basically, is what I would say, because that's the stability work that is really needed for those patients who already are inherently unstable. There are several things that probably go into whether or not someone ends up having a lot of damage that ends up being cosmetically important to them, right? So typically, if you have a singleton pregnancy and you're healthy and young, you typically don't have a lot of fascial damage that happens, but it does happen. And so autoimmunity can increase the risk of having those types of things happen. Inflammation in general can increase the risk of having more fascial damage that occurs even in a singleton pregnancy. When you have multiples, that increases the risk because there's just so much greater stretch that's happening. And then subsequent pregnancies close together also will increase the risk of having fascial damage just because healing has not happened. And that's an interesting thing to me because after a cesarean section, there's guidance for women that says don't get pregnant for 18 months. And the reason for that is because we don't want to stretch the uterus that close to surgery again. But there's no guidance for women after they give birth vaginally of like how to effectively space children. And there are effects that happen, and it's weird because we're talking about when to have people, right? So it changes the conversation a little bit. But when you have children close together, your soft tissues have been expanded drastically. And then when they don't actually have the opportunity to recover fully, and then you kind of re-injure them, so to speak, with a large load and lots of stretching, that can increase the risk of damage that then becomes cosmetically important. So when I say cosmetically important, that's usually like the woman doesn't feel like her abdomen can sit flush with her body. Like it's protruding forward, and she has what people refer to as like the mom pouch, because functionally speaking, she has a diastasis and she doesn't have the necessary tension within her abdominal wall, or she has a bunch of stretch marks that have kind of left her abdomen looking in a way that she doesn't necessarily feel comfortable wearing a two-piece bathing suit, even if she, like, from a shape perspective, would feel okay with that. So I think there are a number of risk factors associated with it, but actually connective tissue disorder isn't one that would respond to surgery well, according to Dr. Pyle.
I have a lot of what I would call level 8 evidence in my life. Like if there's 5 levels, this is like well beyond it. It's just what I feel like. It's just what I've seen. And there's some other things with EDS too, in terms of operative risk and other things. So it is definitely a different population. You did say cosmetically, and I would say like what's super interesting and I did not expect as doing what I do is there's a fair number of people who come in with that, the cosmetic issue, loose skin, stretch marks, things like that, some shape change. Probably a third or so of the people that I see are like, I don't really care that much about that. I just wish that my core muscles were back where they were supposed to be. I've gone through therapy, I've had PT, I've had chiropractic, I've had these things. And then it's like, there's just so much you can do to physically move and change the position of a muscle outside of physically moving and pulling it back together. And so like, I think the functional benefit brings more people in than I would have expected. And especially what we're learning about aging and how, like, you get into your 70s and 80s and so on. And if your core muscles are weak and they're in the wrong place and they're not set up well for success, there's no doubt in my mind that a person's last 2 decades or whatever of their life are going to be harder if their muscles aren't functional. I think that's the one thing that doesn't come across very well in our marketing or our branding as plastic surgeons, but it's a super functional operation, I think, for most people, I hope.
Mm-hmm.
Well, I think too, Lindsay, you said that, last time we were together, you always think of the diastasis recti being like splitting of the fascia, the linea alba, and things like that. And you actually said that, they're finding that they can also have like a muscular tearing component to it. So
Yeah, that's a good point.
yeah. So how has that changed the approach?
Well, I didn't do it consciously, and maybe everyone does it. I don't know. But the diastasis that I see when people are fully relaxed on the operating room table is oftentimes very different than they would have measured at home. So sometimes people come in, they're like, it's 2 fingers, it's 3 fingers, or they'll say like, how many is it? And I have to say, because I won't lie to people, I'll be like, I don't know. Like, I'll tell you when I'm in there. I know it's enough, but really what I think is probably more important is that the muscle that was, this wide when she was 16 years old has kids and it gets separated, but also gets widened and you get this like rounded shape in the center of the muscle that's not what it used to be. And so now instead of like taking the 2 centimeters in the middle and putting it together, the repair is often 8 or 10 or 12 centimeters and involves a lot of pulling the muscle fibers and imbricating the muscle fibers back together so that they're all vertical again. This is my theory. Again, level 8 evidence here. And then the muscle fibers are contracting vertically instead of like around a parabola. And I have to imagine those are functionally more important. And the reason I say that is there was a person on our team who had a tummy tuck, and she came, this was like 5 or 6 years ago. And she came back and she's like, "Hey, Pyle, I'm taller." And I'm like, "You're ridiculous." And she's like, "No, my posture's better." And I'm like, "No, it's not." And then she showed me her before and after pictures, and I was like, "It kind of is better." And I started to look at everybody and I was like, "Man, everybody's posture is better." And so there's this like thing that happens where people don't like how far their belly sticks out, or like they don't like answering the question, "How far along are you?" And they're like, "I'm 4 years postpartum." Um, and there's like this lower back pushing forwards. Like there's probably, I don't know, there's probably some pelvic tilt stuff happening, and like it exaggerates the thing, and you pull the muscles back together, and A, that creates some more flatness in the front. But B, it allows, I imagine, I'm curious of your guys' perspective, like, is there any reason to believe that wouldn't allow the rectus or the erector muscles in the back to sort of chill out a little bit and lengthen?
No,
I'm curious.
I mean, the transverse abdominis comes to mind because there's a direct connection with the thoracodorsal fascia in the back, which is directly connected to the paraspinals. So to me, that is like an absolute connection. So
It almost sounds like an emotional way to correct lower cross syndrome.
Yeah.
Right. So like we have now more confidence in the way that the abdomen is being loaded. So then the posture is responding, not even just to the physical restructuring of the muscle, but actually because they're now like, oh, I can stand upright without having this sway back position. So that's kind of a cool response. And that actually is one of the things that I have noticed with your surgeries in particular versus other surgeries. In other surgeries, because the skin is being pulled so tight, they actually end up with worse posture post-operatively because there's so much tension that they're being pulled downward as opposed to even being able to stand upright. Can you speak a little bit to what you had talked about with the progressive tensioning and what you described to me about what I was seeing of the difference where the scar is actually created?
Yeah. So there was a gentleman that I joined named Glenn Davis 12 years ago, and he had been doing a type of abdominoplasty that was marketed as a drainless abdominoplasty. But when surgeons talk to each other, we call it a progressive tension abdominoplasty. The story behind it is kind of interesting. It was a father and a son plastic surgeon in Texas in the 90s. And the dad went on vacation, and the son saw one of his abdominoplasty patients post-op while he was on vacation. And he like his dad got home, he was like, "Man, we got to talk. Maybe you're getting too old for this. You forgot to put a drain in that person." And he's like, "Why would I put a drain in?" And he's like, "Because you did a tummy tuck, Dad. You talk to your parents differently than you talk to any other human." By the way, this is all made up. Like this dialogue may or may not have actually happened. This is how it happened in my head. But you forgot to put a drain in, Dad. And he was like, "Why would I put a drain in?" And he's like, "Because you did a tummy tuck." And then he's like, well, what does that have to do with a drain?" And he's like, "You always put drains in a tummy tuck." He's like, "Why you need a drain?" And he's like, "Because you did." It was like, this back and forth, who's on first situation. And it turns out the guy had taken a technique that we had used in the back, and he thought it was just how it was done for other surgeries. And he thought that it was just how it was done to basically reconstruct the layers. So during a tummy tuck, if you imagine a person laying flat on their back, and the incision's down here and the muscle's down here, the first part of the surgery is to lift up the muscle skin and the superficial fascia off of the fat skin and the superficial fascia off of the muscle so that I can get in and repair the muscle. And once the muscle's repaired, in the old days, and we've removed skin, so say the belly button is here. In the old days, we used to just like take this top layer and pull it to the skin down, but you would take the top and the bottom together, and that area where the scar was held 100% of the tension. So a couple of layers of suture were put into that. We would lift people up really aggressively, fold them in the operating room so that we could get those two layers together. And then we put drains in below because fluid tends to accumulate in spaces after surgery. And there was a big space where the muscle had, or where the skin had been lifted up. And this progressive tension technique was to take sutures and essentially just take and sew those layers back together. But rather than, we've got a space where the skin is now absent. So rather than just like sewing it back together and leaving a space, that would be a weird decision. There were stitches that were in a different place on the skin than they were in the muscle. And each one would pull the skin down a little bit, a little bit, a little bit, a little bit. And so the skin would get gradually pulled down. 15, 18, 20, or 30 of these stitches would be put in to help offload the tension on the scar and move it progressively from one stitch to the next. That's why it's called progressive tension. From the top to the bottom, there's progressively offloading of that tension, so that when the top layer of skin is brought all the way down, it's now sitting just adjacent to the lower skin, and there's no tightness there. That's why it doesn't do the quarter bounce thing you're talking about. And so like that wasn't a me thing. That was created in the 90s, well, probably well before that, by this gentleman down in Texas. And strangely, there's like still a fair amount of reticence in the plastic surgery community to do that surgery. Younger surgeons do it way, way more frequently. Older surgeons who didn't train in that environment were like, this is how I do it. I'm not changing. But it's like about the only thing in plastic surgery where I would say like, hey man, or to a patient, like, hey, if you're going to have this surgery, it doesn't have to be with me. It doesn't have to be with somebody in Amelia, but it should be a progressive tension version of the thing. It just changes the scar position. It changes the skin load. It changes the shape. There's just so many benefits to the thing. It also decreases the risk of the surgery. So fluid collections are less, bleeding problems are less. There's a whole bunch of other things.
Well, it makes sense too, because when we talk about the abdominal wall, and Brett, I know you've talked about this at nauseum, we have progressive tensioning that occurs in the normal functioning abdominal wall, that is progressive tension on the entire barrel of stability all the way down into the lower extremity even. And so having the progressive tension and not just one fixed point is really how the abdominal wall functions in the first place.
Yeah.
Because early on, it was thought that the linea alba was kind of created that fixed point for everything else. But now that we've kind of really talked more things in depth, like even, it's more research, that it's more the progressive tension around the entire abdominal wall. Would you agree?
Yeah. Not just 360 degrees around, also like with depth, well into the pelvis. So it's not just a pressurization around, it's also like a vertical pressurization. That's really important.
Mm-hmm.
So
yeah, it's genius. And then I think to your point too about the scarring. So does the scar, I know you say you can't necessarily pick that out from the general public, Lindsay, but what does the scar actually look like different from regular, the first technique that you talked about, as far as from our perspective?
Are you asking me or are you asking Jeremy?
Either one, yeah.
From my perspective, the scar is significantly more taut and simultaneously like feels weaker. So a scar that I have seen that has come that is not using progressive tensioning, when I go to work on that scar, I am not putting a cup anywhere near that scar, because it is like, if I put a cup 3 inches away from it and I start to do a little bit of decompression, that scar is getting red. Right. Like it's already kind of reacting to something happening within a couple of inches of it. And I can't work as well or as quickly through starting to help return some proprioception to that area. And that's one of the things that I think is so important, and why I've gotten really excited about working on abdominoplasties is the return of sensation. Because after we do that large amount of surgical work, most women don't feel their abdomen in the same way any longer. And that's what I discovered with working with cesarean patients, was they couldn't feel their lower abdomen any longer, and how impressive to them it was to be able to just feel that area of their body. So then with a tummy tuck, the same exact thing is happening. It also ends up being hard though to return that proprioception to the area. And I think it's because there's so much tension that's brought just with the cutaneous nerves that we can't actually return as much proprioception in patients who don't have the progressive tensioning. So the scar, from what I can see, is basically tighter and weaker without the ability of the surrounding tissues to be as well innervated as they had been prior to surgery. Whereas with progressive tensioning, those scars are inherently stronger because they have come from tissues being approximated instead of tissue, like the scar is not holding and pulling the two pieces together. The scar is formed because those two pieces have been brought together. So that, from my perspective, that's what I see. We'll leave it to the expert to
Does
say if that's
loose
right.
skin and stretch marks, do those always exist together? Or are those not
Now
necessarily?
you can think of a stretch mark as a cut on the deeper surface of the skin. So, you know, if you've got a cut on the outside of your skin, you put stitches in to reapproximate things. But if you've got a cut in the deeper surfaces, which is kind of what a stretch mark is like, you can't put a stitch in that thing. So you get like weaker, thinner, atrophic tissue where only the outer part is together.
Right.
And the skin cells that make scar and that make healing are in the deeper tissues, not the superficial tissues. And so like you've got this thing that promotes healing, but it's absent in those areas. So that's why they end up so wide. And yeah, I was thinking about what you were saying, Lindsay, and I was like, I think I realized something as you were talking too. And same guys, the like part of the way a tummy tuck is done is for the sake of aesthetics. And if you look at a natural abdominal wall, it has three dimensionality to it. It has undulations, and especially ideally, there's like a little bit of fullness in the center, and then like some hollowing out right next to I don't have it in my body. That's why I'm hiding it on the screen. But you know, you can like, so liposuction ideally mimics that. So we will intentionally do liposuction lateral to where the muscle repair is being done and lateral to where we're leaving just a little bit of fullness to mimic the appearance of a normal abdomen. Well, liposuction does this thing where it's like another word for it would be discontinuous undermining. So in the old days of doing surgery, in order to pull things from one place to the next that were tight, like we had to loosen it up as much as we could. So we literally separated the connections over a much wider space. Now, because we do liposuction way more aggressively and way more frequently with tummy tucks, I don't have to undermine or separate the tissue in those areas. Instead, I'll make 1,000 or 2,000 or whatever the number of it passes with a little metal tube called the cannula that separates out some of the stuff and creates some looseness, but not completely obliterating those connections anymore. And I suspect they heal back down like that and recreate some of that tensioning system that you talked about. So I bet it is partially, I'm just thinking about this, partially the progressive tension, and it's partially that the way the liposuction that we do now, but didn't used to do, and some older surgeons specifically, not always older, but it tends to be that are very afraid of doing liposuction with tummy tucks because they were taught that it was not good, that it was increased risk, that there was danger associated with it. But now that we do it way more aggressively, I bet that's part of the thing too. The idea that you keep some of these internal tensions. That's cool.
Yeah. Very cool.
And then how much do you, Dr. Pyle, think of your job as like being an artist versus someone who's just like fixing mechanical things? I mean, are you like looking at every individual abdominal wall and saying, this is what it should look like, or is it not that quite in depth or
I mean,
yeah?
it probably is. Like Lindsay was there, you know, when I'm doing liposuction for a tummy tuck, it may be 45 minutes of just like staring at an abdominal wall with a metal tube in my hand. So I bet there is some of that like artistry, if you will, that comes with it. But if you asked me to like draw a bunny rabbit, it would be unrecognizable. I am not an artist. And then I'm hugely appreciative of people that have that skill set. I do not have it. I mean, it probably says on my website somewhere that I'm an artist, but I'm really not.
And then, Lindsay, you kind of talked about the role palpation plays in this, but Dr. Powell, can you kind of talk through like where does palpation play in this, and is that mainly getting the tension right, or you know, like where all does palpation play into the actual surgical procedure?
God, I've never thought about it. Like I'd probably just do it very subconsciously and very unawarely, but it's probably just figuring out like, I don't know, I'm making it up. Like how are we going to move certain parts? Where is it tethered? Where is it stuck? Where do we need to create some looseness? Where do we not want to create looseness? I imagine that's it, but
Yeah.
it's very unintentional. I appreciate that you recognize, but I did not know what I was doing when I did it.
Well, maybe
So
for
what happened was he was talking to me as he was working on a patient, and he said, I don't want you to think that I'm being disrespectful to this patient because I'm looking at you while I'm working on this patient, but I'm actually just feeling what's underneath my hands here. And I was
Oh,
like,
right.
oh, you're palpating. This makes sense to me. I can talk to people and palpate joints all day and still be like very present with what's underneath my hands. And he said, yeah, we actually end up using a lot of that in surgery because a lot of this is going based on feel. So without really realizing that he's using palpation as like the number one tool for how he's assessing this is what he was doing. And that's what he was describing. He's like, I'm not being disrespectful by not looking at the patient while I'm deep in her abdominal cavity here. I'm actually just feeling what I'm feeling.
And what's the rate of occurrence? I mean, if there was 1,000 women who just had a baby, how often are we seeing these problems?
I don't know. I don't know. I have no idea. But I know there's like different levels of bothered by it.
Right.
And, you know, like there's people who are really fit and were always really fit. And then they have a couple of children and they can't do the stuff that they used to do. So that's one level. And they might not have a severe problem as someone who maybe wasn't that or didn't care that much about that, but just like looks in the mirror and has seen some people is like, I'm stuck. I got nothing. It's the number of people in the United States who have a tummy tuck every year is not that many. So how many need it or would benefit from it is probably more than actually have it. But
What about from your perspective, Lindsay?
Yeah.
What's the patient profile of someone that you're like, hey, I think that you would really benefit from this progressive tension tummy tuck?
So I wouldn't personally, I would never suggest someone has a cosmetic surgery. I think that's probably a slippery slope I don't ever want to go down. But I will have a real conversation with patients about, because oftentimes patients show up saying, I heard that you could help me because otherwise I'm getting a tummy tuck and I'm not sure which is a better option.
Mhm.
And so I'll have that conversation right out of the gate now and say, a tummy tuck might be a good option for you. And they're usually completely flabbergasted by that because like they came to the chiropractor and we're, you know, like we don't do surgery and we have all of these non-surgical tools and we're going to keep you out of the hot lights and cold
You got
steel.
macrame on your wall. I mean, come on.
What's that?
You got macrame on your wall. Come on.
For God's sake, you would expect me to not say surgery is a good option. But I just tell them, you know, from a functional standpoint, we are definitely going to be able to improve your breathing mechanics, the function of your diaphragm and your abdominal wall and pelvic floor. I know that the work that we're going to do here is going to do those things for you. To what degree we're able to do that, I can't say. We're going to do a trial of care and see what happens. And to what degree you feel comfortable staying at the level that we can get you to from a conservative care standpoint is entirely up to you. So if we can get you to a point where you feel really great in your body, you're confident in your ability to go and do the exercises that you want in the gym, or you're able to go hike, or you're able to do whatever it is that you want in your life, and you still cosmetically don't feel like you look in the same way that you feel, then plastic surgery is going to be a good option for you. But if there's also the option that we might get you to a place where you feel good but not great, and plastic surgery might be the thing that we could do, and then we would also just follow up with you afterward, because after you have surgery, there is a rehabilitative procedure that needs to follow that in order to ensure that you have been able to integrate the new mechanics that you have available to you post-surgically.
Well, and I'm thinking too, like in our world, easier for you to like address it with a female, but like in our world, you could probably capture that in the paperwork and just say, like, do you have any feelings toward your abdominal wall or something like that? That way you could start the conversation that might be a little bit awkward for maybe a male that would be, you know, dealing with the female. I'm just trying to think of ways that like it'd be way easier for you than it would be for us to maybe start that conversation on the cosmetic part of it. But if the paperwork captured it, then you'd at least have a link into that. Because I have a feeling, I know I've had a ton of patients over the years. I just didn't think they had an option, quite honestly. And now I would say, well, go fly and see Dr. Pyle. But I think that I'm just trying to think of like for the people that are listening out there, like how would you start that conversation? You know, you're in the world, so it's a little bit different.
Yeah. I think though there's an option here in the same way that somebody comes in and, you know, I got an MRI and my left rotator cuff is torn in these places. And you say to them, yeah, surgery is an option for you, right? Let's do a trial of care and see if that's necessary. Like when you say abdominoplasty, people don't know what that means. Right? What they know is tummy tuck. So if you're talking about a tummy tuck, then they're automatically thinking cosmetic surgery and they come in with their prejudice of whatever they think of that, like I did. But if you say abdominoplasty would be the surgical correction for this, you know, let's see if we can get you to a place where surgery is not necessary, or let's see if we get you to a place where surgery would be the next best move for you. Either way, I know we can work together, but like, I think bringing it up in the same way that you would for a patient who comes in and is like, hey, I'm here because my options seem to be try out this chiropractor or get surgery. What do you think? You know, that I think you could have the conversation regardless of if you have macrame on your wall or not. Like, I think that it's an option for people.
No different than talk about pelvic floor dysfunction or anything like that. That's maybe a little bit awkward, but it's just one of those things. If you have
like
the option, then, yeah.
Musculoskeletal expert, regardless of how inconveniently located it is.
Yeah.
I think too, I mean, you could really, really tie it back into function just because Dr. Pyle, one of the main researchers on the abdominal wall, his name is Paul Hodges. He's from Australia, and he's got a line. He basically says, without pressure, you don't have tension. Without tension, you don't have stabilization. So really, I mean, when we're talking tension, although I know in your world, we're always talking cosmetics, but I really, now that we're having a conversation, it probably would also relate to the ability to stabilize your low back well, which I'm sure is not something that was originally in your thought process. But I think that, yeah, I mean, it would be an interesting thing to kind of look at. But I would think there would definitely be a correlation in with or connection between those two thoughts.
Yeah, there are studies that advocate that low back pain is often improved with a tummy tuck, and pelvic dysfunction is sometimes improved too. Can I tell you guys what my theory is on that, and you can tell me where I'm wrong?
Yeah.
Yeah.
Okay, so like first of all, Pyle. Like I think of it as like a chain from the front to the back, and if there's weakness in the chain, the other parts of the chain also suffer a little bit. And if we can create less weakness or more appropriate tension in that part of the chain, the whole chain works well. Am I off?
No, that's what we spend half of our life
Do you-
teaching.
Yeah,
Yeah.
We
absolutely.
just call
I've
it
been
a
saying
kinetic
it.
chain. That's all.
Okay. No, you're exactly right.
Okay.
We have a saying,
I've-
Dr. Pyle, pressure makes diamonds, but it also makes hemorrhoids. So it's like a principle. There's a balance there.
Well, I think you're 100% right too. I mean, you kind of referred to it a little bit earlier too about lessening the tension that's on the erector spine. And when we're talking about abdominal wall function, we don't have any muscles that attach from our spine to the front of our abdominal wall in a direct correlation. So stabilization has got to happen through the kinetic chain. And so
Mhm.
you can do something that improves that coordination between the two, which seems like progressive tensioning is a great option. Then that is, I mean, that is the key to everything right there. So we try to do that with our patients as far as through respiration, with teaching them what their muscles should feel like and should work. But then if that connection is lost because those muscle fibers are so separated and that connection is lost because of all the things we've already discussed, then creating more of that tension in the right manner is, I mean, that is right up our alley.
Phew, I've been telling people that for years, so I feel much better now.
Yeah,
And
absolutely.
what happens, like, I'm sure it's happened before, like on a future, they get pregnant again, then
Uh-huh.
what have you noticed? What are the trends with that?
Yeah, it doesn't happen that often because you do kind of have part of the discussion is like, you gonna have more kids? Do you want to do this before? But sometimes people have been through a life journey such that maybe they've gained and lost 186 pounds and they're 27 years old and they're like, this is miserable. And it's like, hey, if you have kids, it may reverse some of the stuff that I do. And they're like, that's a tomorrow problem. I'm going to solve this today. Um, and in that subset of people, and this is fully anecdotal, I would say that there are some people that come back and you're like, that's remarkable. You look exactly the same as you do in your post-op photos. And then there's some people that come back and there's just some recurrent stuff. But the human body is remarkable. It's way stronger than anything I'm going to do in the operating room. And so it doesn't, having the surgery doesn't seem to in any way impact their ability to have normal pregnancies afterwards.
And I'd hate to bring Satan into this discussion, but does the insurance companies, are they recognizing your services, or is this a cash-based service, or how does that all work?
Yeah, it's like so we used to take both insurance and not insurance patients, and we had to stop taking insurance patients because a number of people would be mad at their insurance companies, and we would become the vehicle for their anger. And so, yeah, stop me if you've heard this before. Um, and so we have just learned that like insurance companies are pretty unlikely to pay for something that they don't have to pay for. And so it's not like all of a sudden they can be like, hey, we think this will make your life a little better. Have you considered it? So my suspicion is it won't be covered, generally speaking, forever.
And then, so what's the ballpark? If you're going to pay cash for it, how much is the procedure?
In the United States, you could pay $3,000 for a place in Miami that you ought not go to. Nothing wrong with Miami, but that's where most of these places are. It has to do with some of the economics of the state or how the rules in the state, I think. Or you could go to Manhattan and pay $62,000 for it. In Amelia, so there's Amelia locations in San Antonio, St. Louis, Evansville, Indiana, South Florida, Raleigh, and New York. And in all those places, which are that is the one place I know how much stuff costs, it's generally speaking between like $8,000 and $13,000, depending on the location, the surgeon, and the type of surgery.
That's
Oh,
extremely
that's totally affordable.
Yeah. And then obviously we focus most of this on females. Obviously males would not be immune to these same type of things. Is that something you're seeing in a population of males? Would that be something you consider? Yeah, I don't know. Maybe I'm dumb for asking that
Asking
question,
for a
but
friend?
yeah, I don't know. Yeah.
Yeah, no. The male patient in the population that we're talking about specifically with abdominoplasties is a very low percent. It's usually people who have gained and lost a lot of weight, and in the same way that pregnancies specifically stretch and push out and alter the abdominal wall, if a person tends to carry a weight on the inside for a long time, then they lose that weight. There was some stuff that was there that's not there anymore, and oftentimes there's some weakness that results. And so it tends to be for men, people who have been through weight loss. If the one person who's a particularly bad candidate for an abdominoplasty is the person who has visceral fat, who tends to carry all of their heaviness on the inside of their abdomen, specifically the upper half of their abdomen where liver and the transverse colon is. Those people are really hard to fix with a tummy tuck and generally can't be fixed. Mm-hmm. So, in that setting, and men just experientially tend to fit more likely into that category than women do, again, anecdotally.
Yeah. Perfect.
So you got to have people coming from all over the place, I would think. It's not just local patients, I can't imagine.
Yeah, for some reason, there's like some hotspots in Alaska that send a lot of people to Raleigh for this.
Hot twist.
And about 20% of who we see, 20 to 30%, depending on the surgeon and the practice, are from somewhere else, and they fly in for the thing or drive in for the thing.
Yeah. So, I mean, if our people that are going to refer people to you, so they, how long are they staying in St. Louis or some of these cities that you're doing these procedures? Like, what's the stay time?
Yeah, I ask people.
Yeah.
Yeah, so I ask people to stay ideally up to a week in town for a tummy tuck because it's a major operation. We got to make sure they're healthy and safe to leave. They won't feel their best getting on an airplane to leave, but it's not to me unreasonable after a week. The likelihood of a thing happening that would require them to be seen again is pretty low at that point.
And then, Lindsay, what in a dream world, where would you see someone like yourselves roll after that surgery? When would you like to see him, and what would your follow-up look like if everything was like dovetailed together like that?
What I've kind of been doing is I kind of treat them like a postpartum woman where 2 weeks I'd like to see you. And the reason for that is not because I'm really not going to end up doing a ton of hands-on work as much as I'm going to put my hands on you in a way that's going to allow you to remember how we talked about breathing before you ever went in for surgery. Because they now have new proprioceptive input coming in, I want to start to normalize that and give them a little bit of guidance on what this rehab journey is going to look like. So around 2 weeks post-op is when I have told people to come back in when they've planned an abdominoplasty and they're coming, they're coming to me for pre-op and then they're coming back for post-op. I say, I'd like to see you around 2 weeks post-op so that we can start to do some like really basic rehab initially. And then I also, so frequently what ends up happening it happens in C-sections, but it also just happens in surgery, is that people will start activity in a way that is not in their best interest for their post-op recovery. And so being able to kind of be one of the first voices that they hear before, like they don't yet feel great enough to go for a run within the first 2 weeks. So I want to make sure that I'm like in their ear a little bit about here's what this actually should look like, because what we have to do now is rebuild the blocks of foundation of stabilization and support before you start getting new compensators on board for how you're going to start ambulating for the rest of your life. So ideally I see them about 2 weeks post-op. I can start to do just some light palpation of the abdomen and teach them how to do that at home. I tend to send patients home with, I want you to look in the mirror while you're touching your own abdomen, staying away from where the scar is for now, like while it still has any scabs or any tape still on it. So this is after a C-section or abdominoplasty. That way they start to remap their brain of what their abdomen looks like. So just kind of walking them through that in the early post-op days is very helpful for some of that, remapping and creating a new homunculus. And then I'll sort of give them, I'll see them less frequently. Like I want to see you once a week for these next 2 weeks. And then I actually want to see you twice in that following week, because we'll start to add in a little bit more rehab around 5 to 6 weeks post-op. And we can start to do a little bit more active loading as they get more of their stabilization kind of built back in.
Beautiful. Love that.
I've stolen that from you, Lindsay, the stand in front of the mirror and palpate and touch and feel. I say that fairly often now. I always credit you, though.
I super appreciate that. It's really important to me. But that's actually really great, because I think that I think so many women are afraid to touch where they have been operated on, and then they end up having a just giant blank space in their brain of where their abdominal wall is, and that is not serving them. So that's great. Thanks.
And then, Dr. Pyle, what about, as far as, obviously you've talked about where your offices are, but if you have a relationship with a plastic surgeon in your area, is progressive tensioning the buzzword that you're kind of looking for if somebody's looking for a surgeon that's going to provide this service? Or what are some other the buzzwords or some of the things you maybe ask if you're interested in this?
Yeah, it's a really good question. Gosh, I don't know. Like that is the kind. I mean, if I was like, hey, this one detail is what I would call the most important detail in this process, is probably progressive tension. And part of that is just like understanding that you're dealing with a person who made a conscious decision to do a version of the operation that's a little bit harder, that you kind of have to go learn again sometimes if you didn't learn it the first time. Like, I didn't learn this in residency in my training. I had to learn it from Dr. Davis, who taught me a couple of years after I was out. So like that's a person who's very often taken an extra step to get a little bit better at the thing and do a slightly better version of the thing. So that's probably a good sign, but it's hard to know.
Yeah, I mean, surgery and chiropractor are kind of similar, right? It's a wild, wild west. Everybody's kind of got their own little take on it and things like that. So
I think different though than I mean, if you're going for such a niched out procedure, you'd be more than willing to probably travel.
I would say so. Yeah.
You know what Lindsay, I'm curious if you have this in your practice too. There's a tremendous amount of guilt about doing anything for oneself when they have a bunch of kids. And especially a thing that like roughly costs what a trip to Disney World would cost. And so you're like, hey kids, we're not going to Disney this year because mommy's getting a tummy tuck. That's a hard thing for most people to get past in their brain.
It's true. It's very true.
I would completely agree with that. I would, I mean, we're not a Disney family, so, and it gave Taylor appendicitis, but Disney almost killed him.
Bad example. Sorry.
And when we go to Disney, we spend $10,000 a day. So I mean that times 5. I mean
that's just on your liquor consumption while at Disney. Is that accurate?
That's a pro tip. You go to Epcot during lunch. That way you can get all lubed up to tolerate. That's called a pro tip there.
But I would agree with you, Jeremy, that a lot of people do have a hard time taking care of themselves, period. But then when taking care of themselves actually means dropping some money, that makes it a little bit more challenging, for sure. I don't know if you guys want to touch on this at all, but I found it super interesting that in the breast lift that you also did some sort of progressive tensioning, because the chest wall is another area where we still have to have an amount of stability. And I thought that was interesting. And I don't know if that is a way that everyone does a breast lift, or if that is similar to the progressive tensioning in the abdominoplasty.
I didn't know I was doing it that way. I didn't do it on purpose. I mean, I knew what I was doing, the steps of the operation. I wasn't making it up on that day, but yeah, I never thought of it that way. No, it's just to stabilize I just looked at it as a functional way what she's talking about is this: during a breast lift, breast tissue is maneuvered and moved and reshaped. And when that happens, like if you want it to take a new shape, you have to put it together in that new shape. And so there's like a 2-layer running stitch that I do to put the breast tissue back together, but I did not think of it from a functional perspective at all. I just thought it would make the person happier.
You're a functionalist. We gotta hang out with you more often. I mean, this is amazing.
While we got you, this is totally off topic. I'm just curious to know what your opinion is. There's been like a resurgence now. Like we've had a lot of female patients who've got their breast implants removed because there's like health risks now that they're kind of starting to associate with that. Like what's the latest and greatest like that people are doing now, or what are your thoughts on that?
Yeah, that's a super complex issue, and it's probably more depth than just a couple of minutes of conversation.
Right, yeah. Sorry to throw that on. I'm just curious.
No, it's okay. I mean, the bottom line is I feel very comfortable using breast implants. in women whose lives are oftentimes made better for it.
Right.
And if a person has a problem, taking out breast implants is not a tremendously complex operation. It's something we can fall back on should something occur.
Do you feel like people are too hyper vigilant on that? Do you feel like it's not as big of a problem as people are, you know, how the internet is and things like that? I mean, are people freaking out too much on it or not necessarily, or?
Well, I think if I was the person having symptoms, like I'd be pretty pissed off if somebody said, "Yeah, you're overreacting." What I do think is that the internet is particularly good at exaggerating extremes, and so like it makes the 2 or 4 or some percentage of people who have an extraordinarily good experience seem more prevalent than they actually are, and it makes the percentage of people who have something go wrong seem more prevalent as they are. What it doesn't do very well is represent like, yeah, kind of went how I expected. That is a very boring Facebook post that Facebook's like, get that out of here.
You didn't get any clicks with that, but
Yeah, that's a good point. Yeah, that's
Yeah.
yeah. Okay. Well, yeah. Thank you.
cool. Lindsay, any last kind of closing thoughts or anything that you that we didn't really touch on that you'd like to? I know this is the whole idea of progressive tensioning is something that honestly could probably be applied across the body when it comes to repairs, and so it's definitely something to think about.
Yeah, I had my eyes opened by being able to see those surgeries, and I think it was really what I wanted. The reason why I wanted to shadow a surgery is because I'm taking care of these patients post-op, but like I've watched the procedures on YouTube. I just really want a better understanding of what's happening. And I happened to pick one of the best places to actually see what's happening, and was pleasantly surprised to discover that palpation is a huge part of what they're using in plastic surgery, that the function of the abdominal wall can actually be improved by this surgery if it is done intentionally, and that this is a way that we can, you know, help bring our patients to their goals, right? My goal with my patients is to improve their core function, but their goal might be to wear a two-piece and feel great. And so if we can have all of those goals line up, like I think there's actually a really great working relationship that we can have with plastic surgery that I was not expecting, but I learned a lot in that surgery, and it really, helped me realize what a judgy bitch I'd been.
Well, if it's any consolation, I think plastic surgeons have created a little bit of that because the media is just declared like this is who we are, and it's Dr. 90210, and it's botched, and it's like since surgeons seeking attention. But like, I have a lot of surgeon friends that you would also be friends with. They're in terms of like finding a person to go talk with. Like generally speaking, you're going to run into normal people, which is what most of us are. I've really enjoyed our conversation in that, like, I feel like I've taken away an understanding of how the thing does what it does. I'm definitely my brain's gonna be reeling for a couple of days on this one.
Perfect.
Is it possible, Dr. Pyle, could we get a couple before and afters? That way we could attach it to our, I think people would be curious to see what it looks like before and what's possible on the afters. Yeah,
for sure. There's a couple of pictures that I particularly like to use because it shows the change in it's a thin person who's strong, or thin people who are strong, so you can see the muscle shape change happen because of the surgery.
Yeah, that'd be amazing.
Awesome.
That'd be amazing. And then when we come to Raleigh next year, we actually get to sit down and do this thing in person, maybe.
That'd be amazing. Yeah, you can all come into
not
this.
The one in St. Louis, Dr. Pyle? Are you ever in St. Louis or not?
You don't like all the other places. Genuinely, the Amelia surgeons and all those places are wonderful. It's Dr. Rafi Fredman in St. Louis, and he's incredible. And if you ever were in that hood, you should go see him. He's really great.
Cool. Love it. Brett, you can finally get your tummy tuck, buddy.
Yeah, let's do it.
He's the man. You should do it.
What do you got for hair loss?
Yeah.
Can we spend 3 seconds on that?
Yeah.
No matter, this is a thing I've learned in my years as a plastic surgeon. No matter what kind of male it is, they care about hair loss. Like it could be a guy who's got dirty boots and sweatpants and like a wrong size shirt on, and he will be insecure about hair loss. That is incredible to me. I don't do that stuff. I appreciate people who do, but you hit a thing.
Yeah, right.
Well,
all right. Well,
he's a little insecure, so
yeah.
I got to keep reminding him, keep him down a little bit.
It sounds like it's really hard to be a man. Is that what I can walk away from?
Not stepping into that trap.
It's way harder to be a man.
Lindsay, you would understand.
Outdoor plumbing so hard. It's just it's so difficult.
Yeah.
Yeah, well, Lindsay, thank you, number one, for enlightening us to Dr. Pyle, and Dr. Pyle, thank you for sitting down with us. I really appreciate it.
My
I'll
pleasure.
put the website in the show notes below, and yeah, stay tuned for next year when we're in Raleigh, and we'll maybe do one in person and get a little bit more in depth. So,
I love
thank
it.
you very much, guys, for being a part of this. Lindsay, thanks for being you. We appreciate you. We'll see
Appreciate
you
y'all.
in a week. Is that right?
Yeah, Adjustathon, let's go.
Yeah, MPI Adjustathon. So if you guys haven't signed up, make sure you're there. So anyway, good luck with patients, guys, and we'll see you next time.
Good meeting you, Dr. Pyle.
Yeah.
Yep.
Same. Thanks, guys. Thank you, Lindsay.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.